have Dr. ANAHITA here. She's a consultant ophthalmologist specializing in cornea, anterior segment, and cataract and refractive surgery from LV Prasad Eye Institute, Vijayawada. And she is going to be presenting another teaching video. On to you, Dr. ANAHITA.
Thank you. At the outset, I would like to thank Dr. Chitra and the organizing committee for giving me this opportunity to present here today. So post-PK cataract surgery is often a daunting task and requires a very nuanced approach to each step. And today I will be sharing my top preoperative and intraoperative pearls to ensure the best outcomes in these eyes. Starting with the preoperative pearls, the first question is, when would you consider operating in such patients? So the ideal time to operate would be when all the sutures are out and the corneal topography is stable. So this is a patient who had undergone PK for macular dystrophy and underwent suture removal in the 18 months following the surgery. And these scans have been captured in the 4 months after suture removal. So here we can see that the keratometry values and the astigmatism are fairly stable. Also, once the cataract becomes visually significant, it is always better to intervene as early as possible, because the harder the cataract, the greater the risk of intraoperative endothelial cell loss. This brings me to my next pearl, which is performing a preoperative specular microscopy. This will give us an idea as to what the outcome of the graft will be after the surgery, and we can counsel the patient accordingly. So this is a specular in a post-PK eye, and here we can see that the counts are fairly good. But if the counts are borderline or low, then the patient will have to be explained that he or she may require an endothelial keratoplasty in the future. Optimization of the ocular surface is an often overlooked point, and a lot of these patients have epithelial instability preoperatively, and they may develop healing issues after the surgery, as can be seen over here. And the importance of a poor ocular surface in the calculation of keratometry values cannot be overemphasized, and we often see a significant change in the K values once the surface becomes healthy again. So now let us move on to the intraoperative pearls. First is, where would we place the incision? Both clear corneal and scleral incisions can be considered. So clear corneal incisions are placed in grafts which are around 8.5 millimeter, or in very large grafts. And the idea here is that the internal lip of the wound must not cross the graft host junction. Also, another good idea, as can be seen in this video over here, is that the internal lip can be widened a little so that there is no undue stress on the Descemet's layer. So this concept of not touching the graft host junction applies not only to the main wound, but also to the side wound, side ports, and all other incisions made, such as that for iris hooks. None of them must touch the graft host junction. Scleral tunnels can be considered in eyes which have very hard cataracts, or where the periphery of the graft is very close to the limbus, as in this case. The merely hydrating the wounds in such eyes is not sufficient to achieve closure because of the distorted architecture that is present. So suturing of the wounds, whether it is the main incision or the side port, is very important to achieve a watertight globe. And the endothelium in these eyes is very precious, and several steps can be taken intraoperatively to protect this layer. One is using the soft shell technique, where a dispersive visco is injected followed by a cohesive one. And the other thing is, between each step, continuously visco has to be injected, especially during emulsification of the nucleus. So here the probe has to be intermittently removed, and visco has to be used to coat the endothelial layer. While performing a phaco, doing an in the bag phaco with low power and high vacuum settings is recommended. And also using a low bottle height will decrease the turbulence in the anterior chamber, which will again go a long way in protecting the endothelial layer. So to summarize, preoperatively, it is better to wait for a stable refraction and for a healthy ocular surface before carrying out the surgery. And knowing the endothelial counts before the surgery will give a good idea as to whether the patient will require another keratoplasty down the line. Intraoperatively, all the incisions must avoid the graft host junction, and suturing them is ideal. Endothelial protection with the help of liberal use of visco and low bottle height and low phaco power settings will protect the decrease the rate of endothelial cell loss intraoperatively. Thank you everyone for your patient listening.
Thanks a lot, ANAHITA. That was a wonderful presentation. I just wanted to ask you, in these eyes where there's more manipulation there, would you just keep them on oral steroids, or would you believe in adding topical steroids, or would you believe in adding oral steroids?
So since these patients are already post-PK, a lot of them would be on topical steroids preoperatively. So the general rule is that we increase the dosage by 2 drops. For example, if the patient is on 4 times a day, we would increase the patient by to 6 times for a month and gradually taper down monthly or weekly until we go back to the baseline that the patient was on. Oral steroids, unless it's a very high-risk graft, I would not consider.
Another thing is, this was an eye with a macular dystrophy, but supposing it was a post-HSV infection kind of a scenario, then in those cases, how would you plan your antiviral dosage?
So we would start the patient on oral acyclovir 400 milligram BD before the surgery, and we would consider as continue the patient on oral prophylaxis for as long as the patient is on topical steroids post-operatively.
And the last question is, how would you debulk the astigmatism in these eyes? And if it is you are planning a toric IOL, what are those extra measures which would you take? When would you do a toric?
So usually, ideally, it is better to do the surgery after all the sutures are out, but that may not always happen. So if the sutures are in, then I would not consider a toric IOL. Once the sutures are out and on corneal topography, the astigmatism is fairly regular, then I would consider a toric IOL.
Yeah. Yes, that or if the BCVA is also good, and that would also be an indicator that there is no irregular astigmatism, and that would be the way to go. So since I discussed the questions with ANAHITA, anything Dr. Arun or Gaurav would want to ask, or Ramurthy or Mohan, or should we go on to the next
I think it's
case?
a beautiful surgery, Chitra, very nicely demonstrated.
Yes.
And exactly what Dr. Ramurthy asked during Arshutak's talk,
Yeah.
I also wanted to, because I don't want too much fluid and turbulence in the anterior chamber, especially in a post-PKI, because it will wash away the endothelial cells. So I would prefer to use something like a soft shell technique of Viscode and BSS plus. I think all these things she has mentioned very nicely. And also, if the cataract is hard, try to make the cataract into smaller pieces, smaller pieces, and so you are totally in the bag and not in even in the iris plane. Of course, definitely not in the anterior chamber at all.
So Rajesh, yes, cornea man. Your thoughts?
It was a very nice presentation, Dr. Chitra, and I really apologize. I joined in late because of I'm still in OT. It was a very nice presentation, very nice points mentioned. Just a couple of things that you told regarding toric. I would say that if it's a young individual and if there is any doubt that that person has to undergo keratoplasty later, then toric should be a big no. If it's a senior citizen kind of, and the graft is absolutely clear, good endothelium, then only one can think of a toric IOL. And the second thing what I feel is that, sometimes after, if somebody has developed a cataract and the graft was done, I think maybe 5, 7, 8 years back, then these individuals are only on a topical steroid for once a day. So in that case, adding 2 times will not work because, even if you remove sutures, you have to, in order to prevent graft rejection in the early period, you have to increase the frequency of steroid drops. So I guess in any cataract surgery, if there's a keratoplasty done earlier, then in that case, risk of graft rejection is there. So we have to increase to at least 6 to 8 times for the first week, and then maybe reduce it, taper it later. And
yes, you should stay connected because the next presentation is also
very nice presentation, Dr. ANAHITA. Just an observation in the sense that you said maybe the surgery was done about 12 to 18 months after the keratoplasty. In case the cataract is there in many of these dystrophies, in spite of the patient not seeing well, you have enough visualization to do a cataract surgery. In those cases, just like we discussed in angle closure glaucoma, would it be a good idea, even if the cataract is not very advanced, to remove the cataract along with the keratoplasty with the original cornea there, doing the phaco and then doing the keratoplasty the same sitting? Because sometimes, even after a well-performed cornea, which is a transplant which has been alive, just any surgery precipitates a rejection. And obviously, there is some amount of trauma to the endothelium whenever you do a secondary surgery. The second question I had, that's more of a query, in the sense that you mentioned about doing a DSEC. doing a DSEC on a cornea which has been transplanted and primary cornea, is it any different?
With respect to your first question, whether we would consider doing a combined PK and cataract as opposed to a sequential surgery, the calculating the IOL power in such cases is a little difficult because once you do the PK, you're changing the keratometry values completely. So there is a higher risk of refractive surprise post-operatively. So doing a sequential surgery is always better. And with respect to doing DSEC in post-PK eyes versus naive corneas, since this is an eye that has already undergone surgery, they might be past. There might the chamber because of that might be shallow, so there might be lesser space in the anterior chamber to maneuver. And also regarding the stripping of the host endothelial layer, the desmers. So in a normal eye, you would not think twice before removing, but in a post-PK eye, when you go to remove, you might disrupt the graft-host junction. So these are the points you would probably consider in doing DSEC in a post-PK eye.